Hi YouTube family, welcome back to another video. It's Mimi again, and in today's video guys, let me just tell you straight up, okay, it's going to be a very long one. All right, I've decided to do one single video that covers everything else that I had to cover gradually. So I'm doing, hopefully I will get to finish this, okay, because it's really long. It's really long. And like I said, it will cover everything that I had to be doing slowly. That's because I've discovered that I take so much time to upload and actually asked someone's opinion, one of the subscribers, and I got the opinion that it's good if I can just do like a lengthy video. It might be 1 hour, 2 hours, 3 hours. It might be very long. But trust me, if you can just like give yourself that time to get to listen to something, at least it's going to help you. Okay. To my returning subscribers, thank you so much. And to those who haven't subscribed yet, please hit the subscription button and make sure to turn on your post notification. Okay. And I really want to say thank you to, you guys are encouraging me. My YouTube family is growing. I'm at over 30 subscribers now. So it's so amazing, guys. Like, I'm so impressed and I'm very, very, very happy for that and motivated. And please, if you like this video, don't forget to give it a thumbs up. Um, Take it at least to like 100 likes. Can you do that for me, YouTube? Just 100 likes, okay? And I'll be super, super grateful. The reason why you get it to that level is so that other people can see it and it can help them as well. As much as you're doing that for other people, you're doing it for me as well, which is why I'm so grateful that we are growing and we are growing really fast, okay? I can't imagine it's almost 2 months since we started this channel and we are at over 30 subscribers. I'm so super happy with how far we've come and I know we are going to go really far, all right? Because this lecture is going to be really lengthy, I think we should just go straight to it. So I might not really take time to explain certain things really detailedly, but I'll make sure that you get the point and it's going to help you in one way or the other, trust me. So let's go to laminectomy. Laminectomy. This is, like you might think it's just coming from nowhere, but laminectomy is a little subtopic that I want us to cover before we get into drug toxicity and stuff like that. So what is laminectomy and why do they even do this? Okay, laminectomy, just from the name ectomy, is like the removal of something, right? So why should people even do this procedure at all? So lami stands for a vertebra or a spinous process or something like that. And then ectomy, of course, is the removal. So it's a removal of a vertebra. So to put it together, laminectomy is the removal of one or more vertebrae, usually to give access to the spinal cord or to relieve pressure on nerves. So when your one vertebra, if you look at, where the spinal cord is, right? So the thing that covers the spinal cord are the vertebrae. And if they remove it, it's maybe because there was so much pressure on the nerves that goes from your brain down through your spinal cord. That's because there was so much pressure on those nerves, so much such that they had to remove a vertebra, this bony structure, to be able to give space for this nerve to breathe, to be free from this pressure. So if there is pressure on a nerve, they will have to remove that part of the bone that is putting that pressure on that nerve. Okay, so it's either done to give access to the spinal cord or to relieve pressure off of the nerves. Those are the two reasons why laminectomy is done. So now some people might be suffering from this condition where the nerves are being pressured, or there's so much pressure on the nerves, or the spinal cord is so much covered up that it doesn't even have space to breathe. And the signs and symptoms that you see with these people who have nerve issues that needs a laminectomy are, you see pain, of course, there's paresthesia, that's numbness and tingling, and there is paresis, that's muscle weakness. These are the three P's for that indicates that a laminectomy is needed. Okay, those three P's. So the most important thing about laminectomy is that you need to pay so much attention to the location, okay, to the location, because when a laminectomy is supposed to be done, your spinal cord, they will divide it into sections. Okay, you find C1, C2, C5, you find things like I'm just giving examples, all right, because the spinal cord is divided into three parts. It's divided into three parts. So you need to pay attention to the location of this laminectomy to be able to get the question correct. So there are three locations for a laminectomy. And the first one is the cervical, which is the neck, okay? The second one is the thoracic, and the third is the lumbar. I'll go over them again. So the first location for a laminectomy could be on a cervical location. So cervical, which stands for the neck, controls your breathing, okay? How the diaphragm moves during breathing. It also controls your arms and your head. So the nerves that are found in this cervical location, they are around your neck area. They control your breathing, they control your arm movement and all of that, and they control your head movement and all of that, okay? So the nerves, please get me correctly, the nerves that control the cervical area of the spinal cord, they help you with breathing, they help you with arms movement and with your head movement, okay? And then the second one is a thoracic. This one covers your upper back. The thoracic covers your upper back, and it controls the nerves in this area, control the bowel movements, and they also control your cough mechanism, okay? And then the lumbar area of the spinal cord is the lower back, which controls your legs movement or leg movement, and and it also controls the bladder, okay? So these are the three locations that are found on your spinal cord, and the nerves in these different locations control different things on your body, all right? So cervical, I said, is the neck area. Thoracic is, the upper back, and the lumbar is the lower back, and they control different things. So to get a question on the laminectomy correctly, you must know the three different locations, and you must know what they do. All right? I don't want to be going over the same things over and over and over and over again. So you know these three locations, and you know what they control in your body. Okay? Yeah. So let me now ask you, if the question is asking about like what is the most important pre-op assessment that you do before a cervical laminectomy? What is the most important pre-op assessment that you as a nurse would do before a cervical laminectomy? Now, what do you know about the cervical laminectomy? You know that the cervical area or the cervical location is the neck area. It controls your arm movement, it controls your head movement, it controls breathing and the diaphragm, right? So when you know these things, you'll be able to know that to do a pre-op assessment for someone who is going to be undergoing a cervical laminectomy, I need to focus on the head area, the arm area, the breathing, and also there's noise in my environment. I don't know where that's coming from. I'm sorry. So you have to know what the cervical stands for to be able to get that question correctly. And now that you know what to assess or where to focus your pre-op assessment before a cervical laminectomy, you will also know where to focus your pre-op assessment before a thoracic laminectomy. And you will know where to focus your pre-op assessment before a lumbar laminectomy, right? So use the same knowledge and apply for a cervical, for a thoracic, and for a lumbar. For instance, what is the most important pre-op assessment before a lumbar laminectomy? Now you know that for the lumbar location, the nerves control what your legs movement and the bladder, right? So what will you assess this patient for before they go in for this surgery? So much such that after this surgery, you'll be able to reassess and see the changes you're looking for. So you will assess their legs movement and the bladder. How do you assess the bladder? Like when was the last time they voided? The pee. Okay, so that's what you would do. Same goes with a thoracic laminectomy. Like you look at the bowel sounds, the last time that this person had a bowel movement, you look at their cough mechanisms and things like that, because those are the areas that these nerves are controlling. All right, and when you do that, you'll be able to get these questions right at all times, every single time. So on this lecture on laminectomy, I want you to memorize, understand these three important locations of nerves in your spinal cord and what these locations control. This is a full human being, right? You're a full person. You have your spinal cord, and the spinal cord controls. It has nerves that do control parts of this body. So the cervical, which is the neck area, controls your head movement, your arms, your diaphragm, sorry. Yeah, your diaphragm and your breathing. So if you know that this is what this location will do for me, you can easily answer a pre-op assessment question or post-op assessment question on a cervical laminectomy. Same goes with a thoracic and a lumbar laminectomy. I don't want to waste too much time repeating the things over and over. I have this problem where if I say something and I feel like it's not well understood, I keep trying to say it in other ways until I feel like it's understood. So, but I know you got my point. All right. So now we're going to look at post-op laminectomy. Post-op. So after this laminectomy is done, what next? So you have to lock roll these patients always. After a laminectomy, be it a cervical, a thoracic, or a lumbar, you need to lock roll them always, because lock roll is always right. Okay. So the first thing is, don't dangle them. Don't dangle these patients. Don't let them sit on the edge of the bed. Okay, they can sit on the edge of the bed for like 10 to 15 minutes, but that's just long enough to overcome, let's say, hypostatic, hypostatic hypotension. God, am I even saying this right? Okay. So avoid letting them to sit at the edge of the bed longer than maybe 10 to 15 minutes. If they are like suffering from this hypostatic hypotension, you can let them sit for like just long enough to overcome this, but don't always let them sit at the edge of the bed, because that will make them dangle themselves, and you don't need to dangle these people. The second thing is, they are not allowed to sit for longer than 30 minutes. You see me sitting upright? Don't let them sit for longer than 30 minutes, okay? They can walk, they can lay down, they can stand up for as long as they want, but they shouldn't sit for longer than 30 minutes. So they may stand up, they might walk, they might lay down without any restrictions, but when it comes to sitting, they shouldn't sit for longer than 30 minutes. So let's look at post-op complications real quick. Post-op complications again would depend on the location of the laminectomy. That's why I said location matters a lot in this laminectomy questions. Location. Post-op complications would depend on the location. So the first one is post-op complications for a cervical laminectomy. Of course, if you know that the cervical laminectomy is that area that has nerves that controls the diaphragm, breathing, arms, and head, you obviously be going to, oh, if it controls breathing. So I can easily find pneumonia as a post-op complication for a cervical laminectomy. Why would you possibly find pneumonia as a post-op complication? Because these people, the surgery was at the point of they cannot breathe properly. Because remember, cervical location has nerves that controls what? Breathing, arms, head, movement. So it's possible to find pneumonia in a cervical laminectomy patient or someone who has undergone cervical laminectomy. Okay? All right. So, what is the post-op complication after a thoracic laminectomy? I bet you know that one because you know the thoracic deals with what bowel movements, and cough mechanism. So, after post-op thoracic laminectomy, you can see complications like ileus because their bowels might not be functioning properly because they had a thoracic laminectomy. Same goes with a lumbar laminectomy because a lumbar will deal with what leg movement and the bladder. You might look at those complications that concern that particular area of the body only, and you always get this right. Okay, always get this right. Let me see if I have an example here. You are caring for a patient with a lumbar oligodendrogliocytoma. Please, I'm not going to say this again. Okay, so it doesn't matter the name that follows the location. For instance, you already got the point. The question is about a lumbar laminectomy. So what is the number one problem? You know that lumbar controls what? The legs and the bladder. So A says airways, B says ileus, C says cardiac arrhythmias, and D says urinary retention. What is your answer? So that's the idea. Just get the idea and you will know what to do because the location determines everything. Okay? So discharge teachings, what you teach these patients when you're discharging them is that you have temporary restrictions and permanent restrictions. Sorry, it's a laminectomy. So for the temporary restrictions, you tell them not to sit for longer than 30 minutes for the first 6 weeks, okay? And they have to lay flat and lock roll for the first 6 weeks. They don't have to drive or lift more than 5 pounds for the first 6 weeks. Those are temporary restrictions, right? Let's go to the permanent restrictions. They should never lift objects by bending at the waist. They should bend at the knees when lifting objects. This goes to everyone. It's always good to lift objects bending on your knees, not on your waist, okay? And then for a cervical laminectomy, this is for a cervical laminectomy only. They are not allowed to lift anything over their head for the rest of their life. Nothing over their head for the rest of their lives for a cervical laminectomy, and you understand why. Another permanent is no park ride, horseback riding, and all of that. They don't have to do those. So this is all for laminectomy. You just needed to know those 3 locations and you're good to go. All right? If you have any questions about that, just, leave the comments and I'll get back to you. Yeah, let's go straight into drug toxicity, which is another interesting part of the NCLEX. They like to focus on this. Remember, they are looking for a safe nurse. To be a safe nurse, you must know certain things that you need to know to be able to be safe. All right, so let's go straight into drug toxicity. The first drug that we'll look at is lithium. They'll always ask you questions on drug toxicity. Trust me, always. It's a very vital part of the NCLEX. Lithium. Um, it's an anti-maniac drug used to treat bipolar disorder, but only the mania part of the bipolar. You know, bipolar has two, mania and depression, right? So lithium is a drug that's used to treat only the mania part of bipolar disease. So you need to know that the therapeutic range of lithium is 0.6 to 1.2. All right, 0.6 to 1.2. Yeah, um that's the therapeutic range of lithium, 0.6 to 1.2, and the toxic levels will be greater than or equals to 2. Lanoxin or digoxin or digitalis is another one, which is really important for you to know. You have to know that it's used to treat atrial fibrillation, congestive heart failure, and the therapeutic level is 1 to 2, and the toxic level is greater than or equals to 2. I think I have latest lab values in one of my books. Where is that book? I have latest lab values somewhere because these lab values I had to, when I was doing UWard, I saw different lab. Okay, so yeah, Lanoxin or digitalis or digoxin, which is used to treat atrial fibrillation, congestive heart failure, has a therapeutic range of, this is my lab value book, guys. So the therapeutic range of digoxin is 0.5 to 2. 0.5 to 2. So anything above 2 is toxic, okay? You need to know those. Please do lab values. There's the lecture on lab values in this book as well. And then theophylline. Theophylline is an airway antispasmodic. It is not a bronchodilator. It just helps the spasm of the airway muscles. So it has to relax. It's just to relax the muscles that were narrowed, and then it does this by widening your airway, right? So this theophylline has a therapeutic range of 10 to 20, and anything under 10 means they need more, and anything above 20 or equals to 20 is toxic. Okay, to be on the safe side, 20 is equally toxic. So equals to or greater than 20 is a toxic level. Phenytoin, which is also called dilantin, is used to treat seizures. Trust everything I say on these drug toxicities. You see them. You see them. All right. So let's go to phenytoin, which is also called dilantin, is used to treat seizures. The therapeutic levels is 10 to 20 again, and the toxic levels is greater than or equals to 20. So you've seen two 20s already. And the fifth one is bilirubin. Bilirubin is not a drug, okay? It's not a drug, but it's a waste product from the breakdown of red blood cells. And the boards like to test this, especially in newborns. Especially in newborn, because I think I saw this a lot when I was doing UWard too. Bilirubin. And boards like to test it in newborns especially. Therapeutic level is less than or equals to 9.9 is therapeutic. Less than or equals to 9.9 is therapeutic. Let me look at my lab value book and see if, 9.99 is therapeutic. Or you say 10 to 20 is therapeutic. But I'm going to break this down for you to understand something, okay? So therapeutic levels is less than or equal to 9.9. Elevated levels ranges from 10 to 20. So when it hits 10, it's starting to be called an elevated lab value for bilirubin. Okay? And when it hits, let's say 14, it starts to be concerning. Because from 10 to 12, maybe sunlight can help with this, but once it hits 14 and above, I think they need to hospitalize this child. And when it gets to 20 and above, of course, it's already getting dangerous because this bilirubin will get into the brain and it will cause what is called connectherus. And these children will hardly survive this. Hardly survive this. Okay? So why do they test it in newborns? Because there is what we call jaundice, which is normal bilirubin in the body, and there is connectors, which is bilirubin in the brain. And before bilirubin gets to the brain, it means the levels have gotten to 20 and above. It gets to the brain. And when it gets there, it will cause what is called aseptic meningitis or a septic encephalitis. Okay, and there's one way you need to know when you see these children who have bilirubin in their brain, that's connectherus, you see them always assuming this opistotonus position. Okay, when you see a baby in this position, it means that there's bilirubin in their brain. Okay, yeah. So they are hyper flexible, hyper extens. They are just look it up on Google. You see an opistotonus position and you understand what I mean. So when you have these kids in this position, don't place them anywhere else but on their side. Place them on their side, okay? Sideline position. So there are two types of jaundice. There is physiological and there is pathologic jaundice. There's physiologic and pathologic jaundice. For physiologic jaundice, this one is normal, okay, and it's bilirubin at birth, but it gets high over the next few days, like 2-3 days or something like that. It will lead into what we call pathologic jaundice. So what's physiologic jaundice? This is the jaundice that this child comes out with at birth. Am I right? No. So pathologic jaundice is jaundice when a kid is born and comes out yellow, pathologic. But physiologic jaundice is this one happens after like 2 to 3 days after birth. This one is physiologic. But pathologic, this child is born with this jaundice. Okay, yellow. Those are the differences you need to look at when it comes to jaundice in newborns. There is physiologic and there is pathologic. And like I said, pathologic jaundice is the kid is born and comes out yellow. Physiologic is after 24 hours. Pathologic is in the first 24 hours. Yeah. So that's it about drug toxicity. But there are so many other drugs that have this as well, but we just looked at this. Even aminoglycosides, they have the same thing that we'll look at when we get to them. Now let's go to something really quick. Dumping syndrome and heterhania. Dumping syndrome. These are both gastric problems. Dumping syndrome and heterhania, they are both gastric problems. And this is a very fertile, again, a very, very fertile part of the NCLEX, or boards like to test on this. And these two are really opposite to each other. Dumping syndrome and heterhania, they are opposite to each other. Okay, so let's take heterhania first. So this is a regurgitation of acid back up into the esophagus, which is not supposed to be so. Now let me try to explain. Heterhania, you see your stomach? The stomach that is okay in whatever shape it is, has like the sphincter that when you eat food, before it gets into the stomach, there's a sphincter that the food that opens to let the food in, right? So when you eat food and you have this heterhania problem, so wait, heterhania is when this part of the stomach squeezes itself through the sphincter, the upper sphincter, and then forms like a small pouch, like a small stomach before the sphincter. Are you understanding? It's like you have this is your stomach, right? And then part of this squeezes itself and stays here, so much such that when you eat food, the food comes and stays in this small part that is above the sphincter, and the food doesn't go down into the real stomach itself. So it's like you have two stomachs, but one is a fake one because is this original stomach that squeezed itself through this opening of the sphincter and is now, like a stomach. So when you eat food, the food goes and stays in this fake stomach. And because it cannot go down through the sphincter into the stomach, you suffer from this backflow of this of this gastric content. It backflows and backflows and backflows and causes what we call heterhania. Okay, so it's like you have a two-chamber stomach, like a cow who has a two-chamber stomach. So that's what happens with heterhania. The stomach squeezes itself and you have another chamber here and you have the real stomach chamber as well. So with this condition, these people suffer from backflow. Okay, from the explanation, imagine that you have that chamber here and there's another chamber here, but there's no way food can go down easily to the other chamber. What happens is that the food you eat will either stay there and get back up, but it will be difficult for it to go down. But the main thing is when you eat food, you want the food to go through your stomach and gets digested and gets out of your system. The waste product gets out of your system, right? But with heterhania, when you eat food, the food finds it really difficult to go down through the stomach and, follow its path. So you will definitely see things like GERD with heterhania. There will be GERD, okay? And what is GERD? GERD is indigestion and and what is it called again? Heartburn and indigestion. That's GERD. So, and now GERD is only a sign and symptom of heterhania if this occurs when you lay down after eating the food. All right? So when you lay down after eating and you experience GERD, which is heartburn and indigestion, then you're suffering from heterhania. That's a heterhania problem. But if you eat food and you go about your day and then you start feeling the signs and symptoms of heartburn and indigestion, that is not heterhania. This heterhania is only a problem. I mean, you can only say your heartburn and indigestion is caused by heterhania if you eat and lay down, and after laying down, you start experiencing this sign and symptoms of GERD. Okay? I hope you got that. So we will look at how you can help someone who is suffering from heterhania. So straight away, let's look at if a patient is suffering from heterhania, okay, you have three things to do to help this person who is suffering from this situation. All right, there are three things, there are three ways you have to manipulate to be able to help them. All right, so Remember, with hiatal hernia, there is another chamber of the stomach that's collecting the food that you're eating, and it's making it, and it's difficult for this food to pass through this your sphincter, upper sphincter, to get down to the real stomach and follow its course. That's what is happening with hiatal hernia, right? So in this case, you have to play around with three things. First thing is you play around with the head of the bed. When you're feeding patients with hiatal hernia, you have to make sure that the head of the bed is elevated. Don't put them laying flat to feed them, because you only aggravate their symptoms. So you have to elevate the head of the bed. So you play around with the head of the bed by elevating it. You also play around with the water content of their meal. So what do you do with the water content of their meal? You give them like highly liquidic meals, not super solid meal, so that it can go through the stomach faster. It can pass through, the sphincter and go through the stomach faster. And the third thing you do is you play around with their carbohydrate content. All right, play around with their carbohydrate content. So you have to know the high carbohydrate contents of meal, they digest really fast. So you need to give them high carbs, so that this can go through the stomach faster. High carbs digest faster than low carbs. And there's one thing here: if you're giving a patient a high carbohydrate content meal, you should give them a low protein and a low fat content. I don't know if you got that. So you're giving people with hiatal hernia a high carb content meal. That's because this meal will digest really fast, right? And that's what you want, so that these people should not suffer from GERD. So if you're giving them a high carb content, make sure you lower their proteins and their fat. And the reverse is true when we look at dumping syndrome. Okay. Now, what is dumping syndrome? Just from the name, dumping syndrome. When you eat food, it's normally supposed to go down and get digested, and the waste products get out of your body, right? So with dumping syndrome, what happens is that this food goes down at a very, very fast rate, faster than you expected. So you eat food, the food doesn't even stay in your tummy, it just goes, shoom, gets out. When you think of that, what do you begin to see with people who suffer from dumping syndrome? They can suffer from things like diarrhea and a lot of things that we will see, of course, as we go. So with dumping syndrome, one thing you should know is that it usually, or it always happens with people who it's more common with people who've undergone like gastric bypass surgeries. Dumping syndrome is common amongst that group of people, right? So we said that the stomach empties its contents super quick into the duodenum, or into the small intestines. That's what is happening with dumping syndrome. Yeah. So the thing is, it moves really fast, and you didn't want that to happen that fast. So when it moves that fast, you will have issues, of course. Yeah. And so the signs and symptoms of dumping syndrome are, they have in they have what is this? Slurred speech, laid back emotions. That's like I have it combined in drunk plus shock plus acute abdominal distress. So these are the three things that you look at to be able to understand the signs and symptoms of dumping syndrome. The person will look like a drunk person. So how does a drunk person behave? They have impaired judgment, they are segregated, and then you have signs and symptoms of shock for these people also, and then they have acute abdominal distress signs and symptoms going on. So they're flushing, they're sweating, there is all that going on with them. abdominal cramping, there is pain, there is nausea, there is vomiting, there is bulboramic, and there is diarrhea, there is blooding, there is distension, there is tenderness, all of that you will see with dumping syndrome patients. So, how do you treat or help someone who is undergoing this dumping syndrome of a problem? Remember how we played with those three things for hiatal hernia? Now it's the reverse, it's the opposite of what you would do with these people. So remember that dumping syndrome means this food is going at a very quick rate that you didn't want the food to go that fast. If it goes that fast, when does digestion really take place? So that's why you need to play around with these three things to make sure that at least you help your patient with dumping syndrome. The first thing you play around with is also the head of the bed. So with hiatal hernia, we saw that you need to elevate the head of the bed when you're feeding them. But with dumping syndrome, what do? You need to let them lay down flat. If possible, they lay down flat and then you turn their head to the side and you feed them. All right? Oh, sorry. And then the second thing you play around with is you play around with the water content of their meal. Remember with hiatal hernia, we gave them highly liquidic uh, meals. With dumping syndrome, we are going to give them what? Really solid meals so that they shouldn't easily just pass out of their body as fast as that happens. So you play around with the water content of their meal by giving them uh, highly solid meals. And the third thing you play around with is you play around with their carbohydrate content as well. So in this case, remember with hiatal hernia, you were giving them high carbs because high carbs digest really fast. But in this dumping syndrome, you give them low carbs because low carbs will take time to digest, okay? So those are the three things you play around with when it comes to hiatal hernia and dumping syndrome. Remember these two conditions are opposite of each other. Okay, so let's go to electrolytes. Electrolytes. Electrolyte is a very interesting, topic that if you grasp the concept behind it, you'll be able to answer all the questions on electrolytes correctly. Okay, um, so you memorize just four sentences and you get all electrolyte questions correct. So the first sentence you need to memorize is about the potassiums, or which is also called the kalemias, right? The first sentence you should memorize is about potassiums, and this sentence is kalemias do same as the prefix except for heart rate and urine output. Remember the kalemias or kalemias are the potassiums, right? Remember we're talking about electrolytes. So the first electrolyte we're talking about is the almighty potassium, also called kalemia, right? So if you understand and memorize this sentence which I just said, kalemias do the same as the prefix except for heart rate and urine output. And what's a prefix? The prefix could be hypo or hyper. So when the sentence said kalemias do the same as the prefix except for heart rate and urine output. So if I ask you a question about hypokalemias, hypo is your prefix. So your focus is on that prefix, whether it said hypo or hyper, right? So if you hear a question that says hypokalemias, you should know that this electrolyte will behave the same as this prefix, which is hypo, which means the body systems will behave the same as the word hypo. What does hypo stands for? Low, right? So if you see something that says hypokalemia, look at it like, know that this patient's body systems will be low except for heart rate and urine output, which will be the opposite. And if you hear hyperkalemias, you should know that the body system will behave the same as the word hyper, except for heart rate and urine output. So if you see hyperkalemias, you should know that it's a high something. So the body systems will be high, but urine output and heart rate will be the opposite, which is low. You get that? So these are the things you will see in a patient who is suffering from hypokalemia. All right, like I said, the prefix is hypo, so this person will go low. All right, but there are some two things that are exceptions which you must pay attention to, which is the heart rate and the urine output. So what happens to a patient who is hypokalemia, who has hypokalemia? What happens to the urine output of a patient with hypokalemia? It will be high. Even though the prefix says hypo, but remember urine output and heart rate does the opposite, right? Okay. So when they say low, you see things like lethargy, you see things like bradypnea, you see things like uh, ileus, constipation, flaccid muscles, reflexes will be like +1 and all that. And then hyper, of course, the same as the word hyper. So your patient will have irritability, agitation, restlessness, aggression, obnoxiousness, loud voices. They'll have tachypnea, and they'll have diarrhea, bulborhythmic. They'll have increased muscle tone, spasms, high reflexes, and all of that. All right. Please take note of those two exceptions for potassium. So let's go to the second statement you have to memorize. Calciums. This statement is about calciums, and it says that, they're also called the calcemias, right? So calcemias do the opposite of the prefixes. Calcemias do opposite of the prefixes. So the prefix hypocalcemia will tell you that what will happen to the body systems of this patient. It will be the opposite. That's why low calciums you see tetany. That's an opposite of hypo. Okay, so the second statement again is that calcemias do the opposite of the prefix. Remember, the prefix is either a hypo or a hyper. Hypocalcemias means this person will do opposite of hypo, so they will be hyper, right? So when someone is suffering from a low calcium, you will see things like every body system will go up, high, okay? What do you see with this patient? Irritability, agitation, restlessness, all of these things that you see that are high of someone. You find them with hypocalcemia. And the opposite will be hypercalcemia. So you see the prefix hyper, which means things will be high, but because calcemias do the opposite, this hyper will turn everything to be low. That's the second statement. The third statement is about magnesiums, which are also called magnesemias. So magnesemias also do the opposite of the prefixes. So if you understand calcium, you relate the knowledge to magnesemias. So calciums and magnesiums will do what? Opposite of the prefix. I hope you're understanding these things when I say do and do and do. I'm talking about when your body has low calciums or high calciums, how does your body respond? So that's what I mean when I say calciums do the opposite or magnesiums do the opposite. I'm talking of what your body does in response to a low calcium level or in response to a high calcium level. Same with what your body does in response to a low magnesium level or in response to a high magnesium level. All right. So those are the things we are talking about. Okay. And the fourth one is about sodiums. Sodiums, we will just look at them like, okay, sodium is a special, we look at it like a special case. Let's see. When you hear of hyponatremia, because sodiums are also called the natremias. So when you see a hyponatremia, just look at it like fluid overload. So if someone is suffering from a low sodium level, just know that this patient is suffering from fluid overload. And if a patient is suffering from hypernatremia, just know that this person is dehydrated. Look at sodium like that. You know, sodium is all about water and salt. All right. So if your patient is suffering from hyponatremia, the prefix is hyponatremia, just turn the entire situation and look at it like fluid overload. And if you see a question that says the patient is suffering from hypernatremia, turn the situation around and look at it like dehydration. You always get it right. All right. So just a recap of these four statements that you need to memorize to get all electrolyte questions right. The first statement is about the potassiums, also called the kalemias. So kalemias do the same as the prefix except for heart rate and urine output. Commit that to memory. Calcium, also called carcemias. Carcemias do the opposite of the prefixes. The third statement is about magnesiums, which are also called magnesemias. They do opposite of the prefixes. And sodiums, also called the natremias. When you see a hyponatremia, look at it as fluid overload. And when you see a hypernatremia, look at it as dehydration. Then you're good to go with electrolytes. All right? Okay. How do you treat electrolyte imbalances? How do you treat electrolyte imbalances? So, treatment for electrolyte imbalances, we will focus on treating one special almighty electrolyte imbalance, which is potassium. You know, that's the one that causes the most problems. Potassium imbalances will cause a lot of crisis. So that's why we are focusing, all boards would like to focus on how you correct that electrolyte imbalance, okay? And before we get into how you do that, never you push potassium IV. Never give it IV push. Never, ever give potassium IV push, okay? You don't give more than 40 units of potassium per liter of IV fluids. Not more than 40 units in 1 liter of IV fluids. Don't do that. If there's a doctor's order that says you should give 50 units of potassium in 1 liter of fluid, you need to question that order. So you need to give maximum of 40 units of potassium in 1 liter of IV fluid, okay? Because high potassium is the worst and dangerous electrolyte imbalance of all. Hyperkalemia is the worst dangerous electrolyte imbalance of all. That's why we will focus on how you do this. Okay, so hyperkalemia, if someone has high potassium levels, remember what potassium will do. The same as the prefix hyper, except for heart rate and urine output, of course, which you already know. So what happens if your patient has this hyperkalemia? Okay, how do you correct that problem is what we will be looking at right now. Give them D5W with regular insulin. D5W with regular insulin. So when you give D5W with regular insulin, this is what happens. When you give this, it doesn't get rid of potassium from your body. Okay, remember this patient is suffering from high potassium levels and we are trying to correct it so that this person shouldn't die. Because hyperkalemia is the most dangerous electrolyte imbalance of all times. Okay, so give D5W and regular insulin. Okay, when you do this, this is what happens. This D5W with regular insulin only takes potassium and hides it in your cells. It picks it up from blood and hides it in the cell. Picks potassium from your blood and hides it in the cells. take it from the blood and hide it in the cells. So when it's doing this, at least it's giving this patient more time to live. Meanwhile, you look for a permanent solution because this D5W with regular insulin is not a permanent solution to solve hyperkalemia. It's just a temporary solution. So it picks up potassium from the blood so that it shouldn't circulate, and then it saves and stores it and hides it in your cells. That's what D5W and regular insulin will do to potassium that it takes from your bloodstream. Okay? So at least that's good because it gives this patient more time while you look for a permanent solution, which is the second option, which is K-exolate. All right? So K-exolate goes into the guts of this patient, sits there, all right, and it's because it's full of sodium. K-exolate is full of sodium. It now trades sodium for potassium. It says, okay, I'll give you sodium, you give me potassium. I'll give you sodium, you give me potassium. So it trades sodium with potassium. It gives sodium to the bloodstream and say, okay, give me potassium. I'll give you this, you give me that. So K-exolate that is full of sodium, it will sit in your gut and it will tell the body, okay, take more sodium and give me more of those potassiums. So now it takes this potassium out of your cells and out of the blood, and then, not out of the cells, it takes the potassium out of the blood and excretes it out of your system, takes it out of your body. Okay? So, the most interesting thing about these two treatments is that they usually go together. Not together, but you start with D5W and regular insulin, and then you bring in K-exolate. So meanwhile, you do them together because D5W and regular insulin will act almost immediately. Meanwhile, K-exolate takes like a longer time to set in. So meanwhile, D5W and regular insulin will be picking this potassium, excess potassium from your blood and saving and storing and hiding it in the cells. K-exolate that will come in later on to start working, which means its onset, duration of onset, before it starts to work, it takes some time. Okay, so this D5W plus regular insulin will be saving this patient's life at the moment while this K-exolate is going into the person's body as it sits in the gut, but it will take some time to work. Okay, so the time that K-exolate needs to take to work, D5W and regular insulin will be doing your patient's body a lot of good by taking this potassium and hiding it in the cells. And then when K-exolate sets in, it will trade sodium with potassium, thereby taking away potassium from your body. All right? Yeah. So if you understood that small thing, you're probably looking at so many questions that you would get right. Okay. So D5W plus regular insulin takes really fast it works really faster, but it doesn't solve the problem. It's just a temporary solution. Meanwhile, K-exolate is it's a permanent solution, but it takes some time to work, which is why they combine these two and give them at the same time, so that the time that the other one is taking to work, the other one would be helping this patient. Okay. Okay. So that's how you treat hyperkalemias, potassiums that are high in your patient's bloodstream. I feel tired already. I feel really tired already. I don't think I can do one long video. Oof, God help me, because we still have a lot to cover, like so much. Ooh. And I don't want to rush over this thing because I want to, be able to really communicate this in the right way. Hmm. Well, we don't have so much left, but I don't think I can do diabetes today because diabetes, I have a lot to explain to you guys. Diabetes, um, insipidus, mellitus. You have also SIADH and all of that. I feel really, really tired already. So I think we're going to end here for today, and I'll continue in the next video. I'm so sorry to um not be able to do one lengthy video. I'm really tired. I don't know if I should, like pause here and continue next time, but it's gonna make it super long. So I think I'll just do it slowly, slowly, slowly. So thank you all for watching. Please, if you like this video, don't forget to give it a thumbs up. To my returning subscribers, I salute you, and to the new ones, hit the subscription button. Please hit that subscription button for me. Turn on your post notification bells, and also drop a comment because I want to see those comments coming in. And don't forget, this channel has a lot more to offer with time. Okay, I promised that I was gonna improve on the quality of the videos, and do it in different kinds of settings. I always like go for walks, so I think one day when I do so, I will sit somewhere in an outdoor environment to do one of the videos, so that you guys can enjoy the fresh air and breeze as well, right? Oh, okay. I'm gonna go find something to eat. Probably um drain my throat a little bit because it feels sore. It feels sore. And to those of you who saw one of my videos till the end, I don't remember which of the videos, I think second or third, I think the third one, which I talked about my acne on my face. So just a quick update, it's really getting better, getting really, really better. I'm using this Himalaya stuffs, and it's really helping. So I have no makeup on right now. I just have my so when I wash with Himalaya, if you want me to do something on that, I'll do it. But I'm so happy that it's clear enough. If you watch my videos, just keep comparing. You see that how I started and where my face was at, and now it's really clearing out. I'm so grateful. Oof, thank you so much. Keep coming, keep those subscriptions coming in. And I promise you guys that we will get better. Okay? Have a good day, have a good night. Sma salama, salam alaikum, au revoir.